Thank you for inviting me, CSI Heart Failure Council, and I've given the opportunity to present my talk on early diagnosis of heart failure. Since the morning, we are listening brilliant presentation, which are directed towards the advanced techniques to deal with the different facets of heart failure. Now, we should visit this basic topic, that is early diagnosis of heart failure, because challenge is to diagnose heart failure early as stage A and B, because there is no point diagnosis heart failure when even attendants will tell you that patient is bloated and patient is having pedal edema, and is C and D, because all the evidence have shown that if start early, then we will reap the benefit of starting early treatment, either in the terms of lifestyle modification, in terms of medicine, or in the terms of any intervention, including the devices. So imperative for early diagnosis is, we all know, that we are suffering from pandemic of heart failure, very high mortality. In hospital mortality 4 to 6%, it goes to 25 to 30% over a period of 6 months. Then over 5 years, it is around 40 to 50%. And what we are dealing in clinics is stage C and D of heart failure, which is just the tip. Iceberg is stage A and B. A is risk factors, those persons who are predisposed to have heart failure, and those stage B, those who are having substrate in some form of biochemical or in some form of echo imaging, but they are not symptomatic. So challenge is to pick up early so that we can definitely do something better for the patient. And these different guidelines have also emphasized the importance of directing our attention towards stage and B for prevention and early intervention of heart failure. So we are dealing with the challenge of heart failure because of increased survival of the patient, and heart failure is just a courtyard of the house. Whatever is the etiology of heart disease, ultimately patient will have heart failure, natural history wise, whether he's treated or whether he's untreated, or whether he's suboptimally treated. So this shows that different registries have also shown that this is a grave problem with high morbidity and high mortality rate. And they, just like this Trivandrum registry, they also have underscored the urgent need for improved management and treatment, and to pick the cases early. So universal definition, we go back to basic sciences, there are stage A, B, and C, and D. So our talk, we should be more attentive towards stage A and B. A is those patients who are at risk of heart failure, not only because of age, but different risk factors which push the patient towards heart failure. There's hypertension, diabetes, obesity, obstructive sleep apnea, CAD, cancer, cardiotoxic drugs. So this is stage A. And stage B is when there is some substrate is there, structural heart disease is there in the form of echo LVH, a diastolic dysfunction or systolic dysfunction, evidence of increased cardiac filling pressure, or some evidence of rising cardiac biomarkers. And C and D, definitely, we all know that we are discussing from morning. So the challenge is normally, that is, reduced ejection fraction starts when there is a clear-cut inciting event, either in the form of cardiac insult, in the form of ACS, STEMI, and STEMI, or some history where we can pick up that, yes, this is the temporal point in the form of myocarditis. But more challenging, 40-50% patients are of near normal or preserved ejection fraction, where process is insidious. Person is elderly, person has many comorbidities, hypertension, diabetes, obesity, CKD, and we don't know whether when all these substrate right from acting individually, they sum up and person transit to the stage of heart failure. You are seeing the patient, you are treating individually, CKD, hypertension, diabetes, diabetologist treating his diabetes, cardiologist treating hypertension, but no one is looking overall when this person is landing into this stage of heart failure, preserved ejection type of heart failure. That is the challenge, to pick up early. So when all these substrate, they go clinically in the stage of heart failure, this is very important to pick up, and it is not so easy because we are more obsessed with reduced ejection fraction type of heart failure, and we most of the time neglect this preserved ejection type of heart failure because we are not doing detailed echo imaging also. So diagnostic challenge is also because of the early symptoms in preserved type, they are non-specific. Fatigue can be very important symptom if looked into. If we compare with the baseline activity of that person, why person is now feeling fatigue? Although it's not showing telling you shortness of breath, but fatigue becomes very important symptom, becomes equivalent to dyspnea, reduced exercise tolerance. And finally, come some co-founders which further confuse the physician. They are in the form of deconditioning, arthritis, anemia, obesity, obstructive sleep apnea, COPD. All this creates confusion in the mind, and we miss the picture. We miss when person is going in the stage of heart failure. So preserved ejection fraction makes it more notoriously difficult to pick up because of this stability and because of so many comorbidities which are existing in the patient. ESC 2023 found an acronym for the early diagnosis of heart failure, that is FIND HF. F is fatigue, I is increased water accumulation, and is natriuretic peptide testing, dyspnea, and finally heart failure. So this is important if we look for in detail and individually look into each alphabet of acronym. We should know that is what are the major and minor criteria, but most of them, they are absent in the early stage of heart failure. They can be major, they can be minor, and we all should revisit these criteria and show how to go back, how to pre-stage this to pick up the early diagnosis. So first we have to identify the high yield patient, what are the risk factors that person is having, and if there is any symptom which, or there are so many risk factors, we should definitely have this baseline biomarker test in the form of NT-proBNP. And when we are doing baseline echo, we should look beyond LV ejection fraction. We should do more detail in the diastolic dysfunction, stage 1, 2, when it passes from 2 to 3 and 4, Valsalva, without Valsalva, or tissue Doppler, strain imaging, or we can utilize hepatic vein or pulmonary vein Doppler also. High index of suspicion is required in stage A and B. Who to be screened? All those patients who are a major risk factor, such as hypertension, diabetes, especially poorly controlled diabetes, sleep apnea, obesity, CAD, or patient of atrial fibrillation, and all these can be present together in the form of CKD or cardio-oncology aspect, that is cardiotoxic drugs, baseline or patient receiving anthracycline, other cardiotoxic drugs, or positive family history of cardiomyopathy, whether it's hypertrophic, dilated, or restrictive cardiomyopathy. We should be proactive. We should at least have one baseline annual NT-proBNP checkup, and then we should proceed accordingly, based on the clinical suspicion, or we should advise echo yearly or 6 monthly in all those who are at high risk with so many comorbidities like diabetes, hypertension, and CKD. We should also revise what is hepatojugular reflux. How many of us are doing this test? We don't do. We start from echo. We should do clinical examination, and reflex will definitely be there when they florid heart failure. But early stages, we should always demonstrate and look for hepatojugular reflux. Patient may not be symptomatic so much at that time when reflux is positive. Power of BNP, especially NT-proBNP and other biomarkers, it should be routinely done and should be liberally used in all those patients who are a high-risk patient of heart failure, whether systolic or preserved type. And this BNP rule out, if definitely it is NT-proBNP is within normal limits, it assures you that definitely this dyspnea is not cardiac. It assures you it is a baseline. If there is suspicion, you can repeat it depending on 6 weeks or 3 months. It is diagnostic as well as it is prognostic and therapeutic also. Normal level effectively rules out most of the time that is a cardiac cause as a cause of symptoms. High level correlate with worse diastolic dysfunction, high level of heart failure, poor prognosis. So NT-proBNP rises in systolic as well as in preserved ejection type of heart failure in the same way. Although the values are much higher in systolic, but in preserve also it follows the same curve, but at lesser amplitude. So this is very important test. Every lab should be equipped with this testing of NT-proBNP. And definitely there are cutoff of NT-proBNP, men, women as per age, and all of us are aware. So I will not waste time, and we can rectify with the age. Single testing NT-proBNP is very important if person has many risk factors and person may not be telling you many symptoms except fatigue or other non-specific symptoms. So it has a high sensitivity. It is excellent for ruling out heart failure, very good in correctly identify patients who have heart failure. NT-proBNP is highly, if it is below the established cutoff, it is highly unlikely it is having heart failure or cardiac cause because sensitivity is above 98%. So the rule out, rule in, and gray zone. Rule out is less than 150 or 300 as per the lab values. Their heart failure unlikely. If it is gray zone, it is between 300 and 450. It is the gray zone. Use your clinical judgment and repeat NT-proBNP after 4 weeks or 6 weeks accordingly. And heart failure likely if it is above 900, above 450 in age around 50 to 75, above 900 picogram per ml, or above 75, it is 1800 picogram per ml. Heart failure is likely. Consider admission and further tests such as echo and further tests as per the clinical profile. And high risk if NT-proBNP first time is more than is in thousands. Heart failure, very high risk. Admit those patients, they require close monitoring and close supervision. So this anti-proBNP, out of all the markers, has withstood the test of the time and very useful and should be used one time, many times for diagnosis and for response to treatment also. Similarly, in suspected de novo heart failure, again rule out gray zone, age-adjusted high-risk anti-proBNP values are there, and we should use it many times as per the clinical scenario. So heart can be healthy, or sometimes heart is under stress. Although patient is not symptomatic, but heart is under stress. When anti-proBNP is above the normal value, we should say that heart is under stress. So repeat proBNP after 6 months or 1 year if it is in the gray zone. Arrange for echo or assessment of heart failure if cardiac dysfunction is definitely present. So heart stress is a new term which means that heart is not healthy under stress as biomarkers are above normal level. Then there are other biomarkers which are promising and which have a role in future also, and these are highly selective cardiac troponin, and these are galectin. Galectin has shown promise. That is, galectin-3 secreted by activated macrophages directly participate in pathophysiology of heart failure by promoting cardiac fibroblast proliferation and collagen deposition. And this active role has led to its description as culprit biomarker, in contrast to bystander biomarkers such as natriuretic peptide, which are released as a consequence of wall stretching or disease process. Elevated galectin-3 are strongly related with increased rate of mortality and hospitalization, both in acute and chronic type of heart failure. Then another important promising biomarker is soluble ST2, which is a member of interleukin-1 receptor family, the biomarker of cardiac fibrosis inflammation, and it is a response to myocardial strain and injury. It is one of the most promising biomarkers for risk stratification of heart failure, providing prognostic information, which is independent of natriuretic peptide. Then GD15 is cytokine, which is released in response to wide range of cellular stress, inflammation, oxidative stress, tissue injury. It reflects overall stress, which is associated with this condition. So it has been a predictor of all-cause mortality in patients with heart failure. So it is diagnostic, therapeutic, and prognostic. Another important is microsomal RNA, which are a small non-coding RNA molecule to regulate gene expression, and a specific circulating microsomal RNA have been found to be altered early stage of heart failure. They are involved in the process of cardiac apoptosis, hypertrophy, and fibrosis. They have been also found to be promising, and future they may be. They found definite place in clinical practice. High sensitive troponin we are already used. That is a florid heart failure. Those patients who are having, that is a upper limit of normal troponin is positive, they are high risk individual and they require urgent attention. Then apart from doing that is a routine LV ejection fraction by different mean, other important things right from the baseline we should focus on. This is what are the LV filling pressure. Detailed 30 minutes examination, echo examination to look for different stages of diastolic dysfunction. At the end of examination, you should be able to answer out that is mitral tricuspid septal velocity, E prime ratio. Focus on left atrium, which is the most neglected chamber of the heart, and left atrium plays most important role in HFnF. What is the left atrial volume, left ventricular mass, left atrial volume index? What is TR, which is showing pulmonary hypertension? Then go to the strain echo. How many are doing strain echo? We are not doing strain echo, not devoting time, especially GLS. Impaired GLS, very early to pick up, below, that is go positive of minus 18%. GLS can very early eye opener that patient will be symptomatic, especially in the cases of delayed MI or in the cases of those patients who are on cardiotoxic drug, that is GLS can open your eyes so that this patient, this substrate should be kept separately and this patient requires more attention or maybe admission. Then annular E velocity, E prime, septal less than 7, lateral less than 10 centimeter per second, average E prime ratio, LA volume index, peak TR, presence of 2 or more than 50% of these confirmed diastolic dysfunction. GLS is a direct measure of myocardial fiber shortening, more sensitive than LVEF. Normally GLS is typically more negative than minus 18. It identifies subclinical LV dysfunction in chemotherapeutic patient, different type of AS, low pressure, low gradient AS, or all those high pressure gradient, hypertensive heart failure, long before LV ejection fraction starts decline. So this bullseye map should be created, and if we need, that should be repeated also, 3 monthly or 6 monthly as per your clinical scenario. Assessment of right ventricular function, that is another neglected chamber, quite difficult, but you should look TAPSE as in 17 millimeter RVS prime, that is less than 9.5 centimeter per second, can indicate RV dysfunction. RV function calculation is quite challenging, require imaging also many times, apart from routine echo and biomarkers. Then we come to provocative testing. A person is telling fatigue and person not directly symptomatic. Exercise echo, supine, bicycle, treadmill exercise combined with echo. We can assess E prime ratio during exercise. Positive test, if it is more than 14, 15, highly suggestive of HFpEF. We can do simultaneous right heart catheterization with exercise. And with exercise, pulmonary capillary wedge pressure is exceeding 20-25 millimeter mercury. Definitely person is in latent heart failure. So if we go with the H2 FPEF score, then we should know whether the patient is heavy, hypertensive, fibrillating, hypertension, elderly, feeling pressure, and then we can calculate the score as such. So this algorithm will show how to proceed, especially with HFrEF, which is quite neglected because no drug has shown 100% benefit in the terms of mortality benefit as compared to so many wonderful drugs which are working in reduced ejection fraction type of heart failure. Why early diagnosis is useful? There are so many evidence-based therapy and guidelines also show early diagnosis. Pick up early, start treating early intervention. Transition will be late, patient will be, the natural curve, you can alter the natural curve of deterioration over 5-year survival rate definitely can be measured. So choose the best drug to treat the substrate. If the person is diabetic, why to choose metformin? Start from SGLT2 inhibitor right from the first. There's no protocol in that. You can start with the best drug right from the beginning. You can start with DEPA, you can start with EMPA. Similarly, underuse of MRA. MRA is found very, 30% of treatment cards showed MRA. Even in systolic heart failure, MRA is highly underused, I think because of fear of hyperkalemia. The fear is unfounded. MRA should be added liberally in the cases of systolic heart failure. Liberal use of ARNI. If the person can afford, why to go through that algorithm, that first ramipril and anything, hit with the best drug right in the cases of systolic heart failure especially. Now evidence is for HFnEF also that you should start from ARNI early. If person is hypertensive and even if creatinine is 1.5 to 2 or in systolic type, right, start from ARNI right from the beginning rather than going through ramipril and then coming to ARNI later on. So all these bodies have suggested that the best drug support the use of SGLT2, EMPA, DEPA, HF trial, EMPEROR trial. They have shown that they stop the progression of early stage of heart failure. And 30 to 40% of our patients are diabetic. So best person to treat diabetes is cardiologist. You should start with GLP-1 agonist, which can be wonderful combination along with ARNI. So you skip all these slides, and finally I will say that this has also been shown in early intervention in the form of CRT, CRTD. It's helpful in stage 2 of heart failure rather than going in the burnt out refractory case of the heart failure. And one thing is that is use of artificial intelligence as a community which can act as a drone, which is collecting so many electronic health records, ECG, data, retinal scan, imaging, echos, and this can collect the data and it can identify which communities, which regions, which class, which age they are predisposed to early stage of heart failure. So I think in future, artificial intelligence can play a very important role in collecting data. Data is always there in the form of smartwatches and computers and health record. It can club the data and how it can translate it practically to identify, because sometimes community, gender factor is there, a socioeconomic factor is there which pushes the person towards heart failure. Here AI can be used wonderfully to predict the early stage of heart failure in the form of atrial fibrillation or ECG. So finally, I will say, think proactively and look beyond all these conventional factors and choose the best drug. 5 pillars in the case of systolic heart failure and best treatment even for the substrates in HFpEF, because definitely it should be looked from the cardiologist's point of view rather than left to endocrinologists to treat diabetes or CKD to nephrologists also. Someone should be supervising overall picture so that you can pick up with the early rise of anti-proBNP as early as possible. I think finally all experts are sitting, even the failure word is misnomer or misleading or discouraging many times, and patient has very negative effect when he says his heart is failing. I think a better term should be used practically, so that because we see very wonderful cases, very hopeless cases looking on the surface, they have improved dramatically beyond our imagination. Only one class is definitely refractory, otherwise 70 or 80% cases can be worked on very easily, and future is also promising. Thank you.